Welcome, everyone, to today's Schwartz Center's Compassion in Action webinar, Reframing Distress, Why Moral Injury Matters. Thank you for joining us. I'm Julie Collier, Senior Director of Programs here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Before we begin, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with a panel discussion for the first 40 minutes or so, followed by some time for questions. Feel free to enter your questions in the Q&A pane throughout the discussion. I would like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. Before I hand this over to Dr. Lown, I'd like to share an exciting opportunity for you to nominate a compassionate caregiver or innovative program or initiative through one of our two awards programs, the National Compassionate Caregivers of the Year Award and the Corman Impact Honors. Please visit our website for more information on both of these recognition programs. And with that, I'm going to hand it over to Dr. Beth Lown, Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. And I know she's excited to get this conversation started.
Thank you. Thank you, Julie. And a warm welcome to everybody who's joined us today for this important webinar, Reframing Distress, Why Moral Injury Matters. For close to 30 years, as Julie has said, the Schwartz Center has been dedicated to strengthening the human connection at the heart of healthcare and supporting health workers so they can provide care that is compassionate, safe, and effective. So when the National Academy of Medicine formed the Clinician Wellbeing Collaborative and released the National Plan for Health Workforce Wellbeing in 2022, we committed to supporting the plan as a change maker. And we want to thank the National Academy of Medicine for cross-promoting this webinar as one of many activities celebrating progress and the announcement of March 18th as the first annual National Health Workforce Wellbeing Day. We are really, really happy today that we're joined by Dr. Wendy Dean, CEO and co-founder of Moral Injury of Healthcare, a nonprofit she founded with Dr. Simon Talbot in 2019. Dr. Dean graduated University of Massachusetts Medical School and trained in surgery and psychiatry at Dartmouth Hitchcock Medical Center. She's worked closely with both the civilian and military medical communities. Dr. Dean is the author of If I Betray These Words, Moral Injury in Medicine, and Why It's So Hard for Clinicians to Put Patients First. And she's also co-host of Moral Matters and 43cc podcasts. Her work really expands our understanding of health workers' experiences and how we got to where we are today. I am very excited and looking forward to your talk, Wendy, so I'm going to turn it over to you.
Thank you so much for that kind introduction. And I'm so glad that we can actually celebrate the recognition on Monday of the Health Workforce Wellbeing, the National Health Workforce Wellbeing Day. That's quite an accomplishment. I'm going to pull up my slides. So I intentionally put this as a reframing distress. We have thought for a half a century about distress in one way, and I think what we're recognizing is how we've thought about it may be an incomplete framing of the challenge. There we go. So as Beth mentioned, I wrote a book. It was never on my bucket list. That was not something that I had ever imagined I would do or expected to do. And as I started writing the book, I had envisioned one thing. I thought it was going to be a book that had 12 or 13 discrete chapters that told different aspects of the distress that health workers face. And in fact, when I was done, as I started doing that research, I let the horse out of the barn and it started tearing across hill and dale, across the countryside in places I didn't expect to end up. And what ended up happening were these chapters all started talking to each other. And I started seeing the same names coming up back and forth. And I realized that this is a much more interconnected problem than what we had imagined healthcare distress was in the past. So against everyone's advice, when a speaker gives a talk, I'm going to start with not one graph, but several. This is why I'm worried about US healthcare right now. There's a paper published in 2023. They looked at the healthcare workforce in 2021 to 2022. These are not intent to leave. These numbers are who has actually left. 145,000 healthcare workers have left. Half of those were physicians. A significant portion of our physician workforce is over the age of 55. And we are about to hit a silver tsunami of folks who are over the age of 65. In 2035, for the first time in our country's history, we will have more folks who are over the age of 65 than are under the age of 18. And those in that age range, that older age range, will need significantly more care. And I don't just mean healthcare. I also mean long-term care, rehabilitation, et cetera, et cetera. So our healthcare institutions are going to be facing an enormous pressure. The AMC estimates that we're between 125,000 and 135,000 physicians short, and the nursing workforce is similarly going to be facing significant shortages compared to the pressures that we will have to care for our aging population. Along with that is this burnout trend that we've seen. Now, it's no surprise that since COVID, our burnout numbers have gone up. But what I find distressing is that they were so consistent and so high before COVID. When 40% of your workforce is struggling, that is not about individual workers who are challenged. That is about an environment that we need to think about and perhaps consider reframing, restructuring. I'm sure you've all heard the definition of burnout. It's a syndrome that consists of exhaustion, ineffectiveness, and can end in cynicism. That can culminate in cynicism. But when Simon and I started thinking about workforce distress about 8 years ago, we would go to our colleagues and we would say, because I was at that time, I was working for the Department of Defense, and I was looking at programs across the country who had clinicians who were at the tops of their games. On paper, they looked amazing. They were doing cutting edge research. They were referral centers for their specialty. And yet, when we talked to them, they would say, I love my patients. I love the work I do. And everything else is grinding me to dust. Those things get between me and my patients, or me and the care I can provide. Those are the things that are challenging us. And Elena Perea is a psychiatrist in Western North Carolina who really summed it up incredibly well when I spoke to her. And she said, this isn't about working hard. I knew what I was signing up for. I knew that I was going to work long hours. I was going to see some really impossibly difficult things. And I spent 25 years of formal education learning how to take the best care of my patients. And the second I walked out into practice, I had to compromise that gold standard. I had no idea how hard it was going to be to get my patients the care they needed. And when Simon and I started hearing these stories consistently, we started thinking, okay, this isn't about burnout. And the people that we talked to they would almost have the same phrase. It was like they had talked to each other and they'd say, oh, burnout just doesn't quite land for me. I don't have better language for it, but it doesn't quite land. And so Simon and I we didn't have better language for it at the time, but we started looking for it. And there was one day when I was doing some therapeutic weeding at my farm. It's really helpful to rip things out of the ground when you're feeling frustrated, and I heard an article on NPR about this thing called moral injury. And moral injury, they were talking about it in drone pilots who never see combat. Drone pilots live in suburban Las Vegas, or in suburban Nevada, I should say. They drive onto the base, they fly the drones, they get back in their car and drive to their families at night. Never see actual, they're not in combat physically, and yet they were experiencing moral injury. And I thought, hey, maybe we can generalize this as well, very much like PTSD was generalized to the civilian population. So what is moral injury? There are two main definitions that are typically used. One is by Shea from the early 1990s. He was a psychiatrist working with the VA population. And he said it consisted of three things. It was betrayal by a legitimate authority in a high stakes situation. And Brett Litz and his colleagues, also working with veterans, extended and expanded that definition. They said it's perpetrating, failing to prevent, or bearing witness to acts that transgress your deeply held moral beliefs and expectations. And we started looking at those two, and we said, when you feel betrayed, you have a moment when you can either acquiesce to that betrayal and transgress your deeply held moral beliefs, or you can push back and resist and avoid transgressing, decreasing your risk of moral injury. So we kind of think that those two definitions are linked. The deeply held moral beliefs in healthcare workers are the oaths or the promises or the professional obligations that we signed on to when we joined this profession. So this diagram is sort of a way to conceptualize how burnout and moral injury are related to each other. And we have an article that will be published next month in Federal Practitioner that will outline this even more, and it'll have text with it. And but we break down the distress that people are feeling into two different components: the operational demands of burnout, the demand resource mismatches that lead to chronic work distress and eventually to burnout, which is the syndrome of exhaustion, ineffectiveness, and depersonalization or cynicism, or the relational ruptures of moral injury, those betrayals that happen, intentional or unintentional, that aren't repaired, lead to transgression, and eventually go on to moral injury. People who experience moral injury, especially in healthcare, tend to focus less on the shame of it and more on the frustration, the anger, that sense of the anger that comes with being betrayed. Now, the other thing to notice about these two is that they can influence each other. They often occur together. So if you see one, you should really look for the other, even though they are quite distinct experiences. And if you don't treat moral injury, it can start to look like the kind of end stage of burnout where there's that sort of depersonalization, learned helplessness. And burnout, if you keep raising your hand and saying to your organization, hey, we're understaffed, we don't have the right supplies, we don't have X, Y, or Z, and you keep getting dismissed, that can start to feel like a betrayal and feed into moral injury. So they are distinct experiences, but they can influence each other. And I'm putting this up, I am not going to explain this, but this is something that we've been working on for the past 2 years under a HRSA grant. We've been working with the Fitzhugh-Mullen Institute at George Washington, the Institute for Healthcare Improvement, and AFT to develop a national framework for clinician distress. And actually, it's for public safety workers as well. So if you want to look at this in more detail and look at the white paper that goes with it, you can find it at wpchange.org. So we know, Simon and I started working on this in about 2015, 16. Our first article was published in 2018. It was clearly well before the pandemic, but the pandemic highlighted and put into stark relief what clinicians were facing around the world, really, but especially what we had experienced, we couldn't look away from it anymore. We couldn't dismiss it. And there was one group from Duke who did a study and used the moral injury symptom scale for healthcare providers, which was adapted from the military survey. They found that 41% of their respondents had experienced moral injury during the pandemic. Another group used the moral injury event scale, and they found that 19% felt that they had violated their own moral code. But more troubling was that 45% felt betrayed by leaders they once trusted. Now, we can't say whether that betrayal on the part of leaders was intentional or unintentional. I would suggest that probably a large portion of it was unintentional or unavoidable. But still, what that leads to is a significant break in trust between the workforce and those who lead. However, what I would also say is that work we've done with a colleague in the UK shows that 40% of leadership also experienced moral injury during the pandemic. So this is not something that's unique to the healthcare workforce, the frontline workforce. This is also occurring throughout our healthcare workforce. And this really, what we are seeing happening is that we have two sides of the healthcare, the House of Healthcare, the administration and clinical care, clinicians. And we both have different goals and different strategies to get to our goals. One is to keep the organization well, one is to keep the patient well. And there is this artificial divide between us. We have stopped really being curious about what the other side of this equation is feeling. So we have two sides of healthcare that are both equally necessary to meet our patients' needs, but we are siloed from each other and we're imagining what the other is experiencing. I would also say that our leadership knows that the frontline is struggling. They see the same surveys that we see. They hear the same feedback that we hear, but they don't necessarily know exactly what to do about it. There are no clear answers. In fact, the National Academy of Medicine in 2019 said, we can't identify one consistent intervention that will effectively address the challenge of burnout. So what they've done is, with good intentions, they have tried to bring in programs that will address their clinicians' distress, even if it's temporary. So we have pizza parties, we have muffin parties, we have yoga and mindfulness and meditation. But one of the challenges is that they're bringing these in from other industries. These are techniques that have been shown to work in corporate healthcare, in corporate America, or in other sectors. But what we forget is what Colin West made really clear in a July 2020 article in JAMA, which is that physicians, and I would say by extension, most healthcare workers in general, are significantly more resilient than the average employed population. So we're sort of bringing coals to Newcastle. We have a resilient population, but there's something else that they're challenged by. So the way I look at it is, we all know how much rest we need. Not that we get it, but we know how much. We know how much exercise we need. We know what kind of nutrition we need to tune our high performance machines and make them optimally functional. But when we put those highly tuned, high performance machines out on a road that looks like this, it's a hot minute before you have a flat tire, a broken axle, or you're just creeping along trying not to get broken. So we need to start doing something about the roads that we're being asked to run on. And I guess, at this point, I sort of think, all right, so when I was writing the book, how did we get here? Like, how did we end up in this situation that we are in healthcare, where profit trumps patients? And as I said to to folks before we got on the call, Milton Friedman has been persona non grata in my house for a very long time. Back in September of 1970, he wrote an article in the New York Times that said the only obligation of a corporation is to maximize shareholder value. So essentially, the end justifies any means that it takes to get there. Now, I'm not sure that was entirely what he was saying, but that's the way it's been interpreted largely. And he probably, that probably would not have gone anywhere at all if it weren't for people like Jack Welch, who was the CEO at GE starting in 1980. So Milton Friedman put this policy or doctrine out into the world, and then Jack Welch used it, and he used it to justify some of the really challenging corporate tactics that are now quite commonplace. So General Electric was known as Generous Electric in the 1950s and 60s. People coming out of high school or college in places like Schenectady, New York, which is pictured here, they knew that they had a decent paying job when they got out. They could be in management, they could be in research, they could be on the factory floor, and they would get a decent wage. But when Jack Welch came in, he started pursuing shareholder value. He leaned down the workforce. He ranked and yanked the bottom 10% on a yearly basis. And he expanded, he offshored a lot of GE's jobs so that he destabilized these communities like Schenectady, so that people like Matt Ramsey, who was in chapters 1 and 10 in my book, Matt grew up in Schenectady. He watched this happen. And when he got ready to decide what his career was going to be, he said, I want something more stable. I want something that is more human and more humane. And he chose medicine, only to find out that decades later, he might be faced with the same thing, but in healthcare. So the last thing that Jack Welch did was that he expanded GE's bank, and it was GE Capital. And it was first used just basically to let you make payments to finance a washing machine that you couldn't afford otherwise. But he realized that you can only make so many things, no matter how much you invest in the infrastructure to build more assembly lines. But making money on money is sort of an infinite opportunity. And so he expanded GE Capital to the point that it became an unregulated bank, and it accounted for 60% of GE's billions in revenue. He also did whatever it took to beat the S&P 500 for 80 quarters in a row. That's 20 years. That is an improbable statistic that you could be that successful. But when he shifted away from making things to making money, he also sacrificed GE's mission. And in 2022, I drove through Pittsfield, Massachusetts, which was another hotbed of GE. And this is what GE looks like in 2022. This is the plant that my father used to visit when he was a salesman. This plant put a lot of food on our table when I was a kid, and it is now decimated. It's gone. But worse than that, we've seen a diaspora of the executives that came from GE and learned Jack Welch's tactics and learned how successful they could be. And they have been embedded in organizations across the country, including one that you guys might all have heard about recently, quite a bit about, Boeing. So when Boeing merged with McDonnell Douglas, Harry Stonecipher came from GE, and he put in place the same management tactics at Boeing that all the whistleblowers are talking about now. Because Jack Welch was so successful with these practices, business schools changed their curricula to follow shareholder primacy. And not only was it a good idea, but it changed corporate legal theory, and it became an obligation, a fiduciary obligation to your shareholders. So now we have business schools teaching this to everybody who wants to manage, and we have lawyers holding them to it. It has changed the landscape of how we do business in this country. That's led to significant hospital consolidation. So the chart on the right just shows you where there have been some very common mergers. They're now not just regional mergers, but they're across state, they're interstate mergers, which are they're flying below the radar of the FTC. And the FTC is starting to get very nervous about that, which I'll talk about in a minute. But when you look at the graph on the left, this sort of scatter plot graph, 2000 is sort of the highest number of the HHI, this index of consolidation in an industry. 2000 is about the place where you'd like most of the industry to be, or even a little bit lower. And in healthcare, we are way far to the right. So our industry is highly consolidated, highly concentrated in most of the urban markets. And what that means is patients have less choice and the workforce has less choice. It can also have implications for things like artificial wage suppression and things like that. What we've also noticed is tremendous vertical integration. And what that means is that healthcare organizations are starting to, they're starting to buy up all of the elements of healthcare. So not just hospitals, not just physician practices, but pharmacies, pharmacy benefit managers, nursing homes, rehabilitation centers, on and on and on. And when I was writing the book, I still remember where I was the day that I realized that the headquarters of US Steel, which was the most heavily consolidated, vertically integrated industry in 19th century, in the early 1900s in the US, the first Gilded Age, that tower has now been taken over by UPMC, the University of Pittsburgh Medical Center, and it is now their headquarters. That was a chilling day. But you know what? I hope this is going to work. I'm going to let Will Glaucomflecken tell you what his take is.
Where have you been, Jimothy? We're buying up hospitals, surgery centers, pharmacies, nursing homes. Please, just stop. Just imagine every interaction you have with the U.S. healthcare system throughout your life, all owned and operated by United Healthcare. I'm going to be sick. You have chest pain? Call an Optum ambulance. They'll take you to an Optum hospital where an Optum cardiologist will give you an Optum stent and put you on an Optum cardiac diet. Even the food? Optum Eats, Jimothy. Half the salt, twice the red tape. My God. People want Medicare for all, but they're going to get United Healthcare for all.
So we've consolidated, we've vertically integrated, but now we're starting to do the same thing that GE did. Healthcare is financializing. Optum has a bank. Optum Bank backs Care Credit. And that means that patients can apply for these credit cards or a loan to afford the parts of healthcare, the portions of their healthcare that they can't afford out of pocket. They'll take, they can put it on a credit card, put it on a loan at the low interest rate of, yes, between 8 and 36% per annum. And when physicians can't make their payroll because Optum hasn't paid them back soon enough, they can take out a loan from the Optum bank and use those reimbursements as collateral. And there are significant consequences. What's happening around the country right now, I think maybe a lot of you have heard about the Change Healthcare cyber attack, which is influencing about 80% of United Healthcare's contracted groups. People can't submit their claims for reimbursement. They can't accept reimbursement. And I heard about yet another practice today that may go under as a result, because when you don't get paid for 6 weeks, if you don't have that money in your pocket to pay your staff, you will go bankrupt. There is also the Steward Healthcare crisis, where private equity invested heavily in 13 hospitals in Massachusetts. Those hospitals now can't pay their mortgage because of some of the strategies of private equity, and they are on the verge of bankruptcy. If those 13 hospitals go under, 200,000 people in Massachusetts will not have access to care, and they will overburden the hospitals in Boston that are already struggling. So there are significant challenges to healthcare as a result of how we've done business. So how do we fix it? I am a firm believer that we created this. These are decisions that we made. So we can make different ones. But in order to be able to do that, we need the blueprints. We need to know how these systems were constructed as they are in order to know how we go about renovating them or tearing them down to start again. What I will say is that we do need to make sure that people who are really struggling have the supports they need. But when we're talking about betrayal, about those relational ruptures, those indicate that our community is starting to fray, that some of the relationships are fraying, that our trust has frayed, and we cannot restore that in an individual therapy room or on one-on-one interactions. That must happen in a community. So last spring, our collaborator in the UK and I were talking, and Deborah Morris, she works in the UK, and we said, okay, so if we're going to steer toward what's right, we need to be able to envision it. What does that look like? What does a non-morally injurious organization look like? And so we did a Delphi survey because we couldn't find one. Simon and I have looked for 5 years and haven't found a place that does it consistently well. So we asked 50 moral injury experts around the world, what would a non-morally injurious organization look like? First of all, they decided that morally centered was a good term for that. And then they said, an organization is like that is wise. They anticipate moral injury and they prepare for it. It is human. It recognizes that it's vulnerable. It asks for help. It is humble and acknowledges its imperfections. It is value-based. It's trustworthy, right? It does what it says it's going to do when it says it's going to do it. It takes care of the next generation and mentors intensely. It is just. When something goes wrong, it looks for lessons learned, not blame. And it's courageous. It's brave enough to ask its workforce to give it feedback and to accept that honest feedback without retaliation. But at the same time, it is courageous enough to stand up to the entities on the outside that are imposing potentially morally injurious regulations, legislation, actions. We need healthy leadership as well. As I said before, they're struggling, but we need them to walk the walk, talk the talk, and to fight for right. So they need us to acknowledge that they also have moral and ethical challenges and values, that we support them in maintaining those, and that they have places where they can talk about it so that they can create spaces for their workforce to also create that. Our leadership needs to be faithful to their word. They need to acknowledge, challenge, and address and resolve moral transgressions and consider the moral impact of their decisions, not just the financial impact. In order to do this, we need to consistently build ethical frameworks on which to hang these moral concepts. Now, as anybody who owns a house knows, you can't just build it and leave it. With any of these frameworks, you have to constantly revisit, you have to constantly repair, you have to constantly practice. And that's what helps embed this in the culture of an organization, is the continued acknowledgement and practice of these principles that in which both the administration and the front line have agreed are aligned values. And to do that, we have to make that divide between the administration and the clinical side more porous. We both need to reach across that divide, be curious about each other, spend more time in each other's presence. And that means that our leadership needs to ditch their suits and come into our clinical workspaces. And we, when we're invited, or we need to ask for invitations, to join them in their workspaces and ditch our scrubs and understand what the challenges are that our leadership is facing, because they, as much as ours are huge, so are theirs. And this doesn't mean that I am at all dismissing the incredible, intense challenges of our frontline healthcare workers. It is remarkable what people did through incredibly challenging times. And really, when we look at what happened in healthcare, the will of the workforce was what got us through, and their ability to extend and go above and beyond got us through. So we need to acknowledge that and honor it, and we need to convey that to our leadership, but we also need to acknowledge that they also struggle, and we would be remiss to miss that. One of the things I talk about is speaking up, but never speak up alone. At least right now, it is still a difficult thing and sometimes a dangerous thing to speak up alone. So build coalitions within your specialty, between specialties, with other licensees, across organizations, within your specialty societies, your professional societies. Find like-minded people. And the challenging thing about healthcare is that it feels very broken. The great thing about healthcare is that it's pretty broken. So wherever you start to make a difference, wherever you start to work, it'll help. The other thing that we really need to do is to educate those who are in positions who have abilities to change the regulation and the legislation at our state houses, at Capitol Hill. We don't need to lobby. We need to educate. So going to those places and saying, here's my day-to-day reality. I'm not asking for myself. I'm asking for my patients. I'm afraid for my patients. I'm worried about the quality of care I can deliver. And I don't know how much longer I can do it. I can't, as one single person, I can't, or even all of the physicians in the country, there are only 1 million of us, right? So we need our patients to stand up for us, and we need our legislators to stand up for us. But in order to do that, we need to explain what our reality really is, because as much as we take it for granted, and as much as we live in this day in and day out, eat it, breathe it, sleep it, very few people have gone through this training. And so they don't understand on a visceral level what it's like, or why our oaths are so important to us. And the more we can convey that, the better off we'd be. The other thing we need to do is to support actions that are in place, like the reauthorization of the Dr. Lorna Breen Healthcare Provider Protection Act. It has gone through one side of Congress. It needs to get through the House. We're hopeful that it will happen, but the more we can tell our legislators why that's important, why it's important to support our healthcare workforce, the less resistance they'll put up to passing this reauthorization. The other thing that is monumental is that last week, just a week ago, the Federal Trade Commission, the Department of Justice, and the Department of Health and Human Services, which oversees CMS, began asking for public comment, open to public comment period, to find out from administrators, from clinicians, from patients, what the impact of corporate greed has been on their experience in healthcare. So you have an opportunity as a clinician or as a family member or as a patient to say, hey, when my healthcare system got bought out, here's what my experience was. Maybe they reduced staffing. Maybe the access in the emergency room got worse. Maybe they closed your local hospital and that impacted your care or your family's care. Go to this. The QR code will take you to a page that explains what this is. There's a part on it that's hyperlinked. There's a public comment phrase in the second paragraph on that page that has a hyperlink. If you click that, you can go and make a comment there, because they know how worried some people are about retaliation. You can comment anonymously. You don't have to associate your name with it. So please go They are looking for opportunities and for data that will help them change how the Federal Trade Commission oversees antitrust actions in healthcare. And the easiest thing to do this year is to vote. So much of healthcare is constrained by the legislation and the regulation that we have. We need to know who that represents us, understands healthcare really well, and has our same values. So how are we going to change this? Who is going to listen to the changes that need to happen? Now is the time to start looking for those people so that in the fall, we can support them and vote them into office. And the point of all this is that for a healthy healthcare ecosystem, not only do we need values-based organizations, but we need a variety of them. We don't just need massive tertiary academic medical centers. We also need community hospitals. We need private practices. We need direct primary care. That gives our workforce an opportunity to choose where they work, because each one of these might be useful to any one of us at different stages of our career, but it also gives our patients choice in where they get their care and how they get their care. And this is just a brief slide to say that we have been working on this, trying to expand and talk about reframing distress for 5 years, right? That is like a minute. It is such a short time. And yet the language is so powerful and the framing is so powerful that we really feel like we've made huge strides in the last 5 years, but I'm also asking people to be a little bit patient with the fact that we don't yet have robust data from trials. We are working on that as fast as we can, but we've only been around literally for 5 years. We've been talking about burnout for half a century. So that data is coming, and keep your eyes out for it. And what I would like you to think about is, as you walk away from this, what are we all? This is about a community. Change is going to take a community, and it's going to take all of us in that community. So what are we, administrators, clinicians, and patients, promising each other going forward? If you want more resources, as Beth mentioned in her introduction, we have 2 podcasts. Moral Matters, which has about 80 episodes, 43cc, which is up to almost a dozen. The QR code will take you to our website that has a ton of resources. Like, I think we've put on there almost everything that we've ever found helpful. And then there's the book. So I'm going to stop sharing and open this to questions.
Thank you so much, Wendy. I think I'm just looking at some of the comments in the chat and people sort of with their eyes wide open saying things like, wow, I think some of this information is new. We don't think as much when we're taking care of patients about the socioeconomics of what has led to the current situation in healthcare, the financial decisions, the policy decisions, all of that, and how long ago this whole shift began. So I think that's an incredible contribution. I will field over some of the questions here. There was one question from a hospital COO saying, he's really encouraged by the work that can be done by going to the front lines and listening, but sometimes he feels like the staff can feel that the administration is here to take over and really the intention is to listen. So how do you go about creating that kind of porous divide? I think psychological safety isn't a guarantee when a leader shows up on your ward. Do you have any thoughts about that?
Yeah, I think if the more you show up, the more you're vulnerable, the more you share, the more you ask, the more you're genuinely curious, and they see that curiosity leads to action, even on little tiny things. Sometimes you have to start very, very small and build the trust that way. But the more you show up, the more you know people, the more they start to know you, the better off.
Right. We've heard a lot about leadership rounds, and rounding. And I think the other thing I've learned, um, especially from our Healing Healthcare initiative, which I'll talk about a little bit more later, but that this can't be a one and done. Like you said, people have to just keep showing up and keep listening and find other ways, not just rounding, but other ways for people to reach you who may not feel safe enough to speak up across the hierarchy and the power divide. So that's an important thing, I think, to be taken into consideration as well.
And
Oh, go ahead, Wendy, go
No,
ahead.
no, and that's one of the things that we try to do as our organization is we recognize that people don't feel safe. We try to find ways to raise awareness in an anonymous way. So by aggregating stories, by anonymizing stories.
Right. Yeah. And I think there are some ways to do that. There are also technological solutions to help that. And in fact, that raises a question that is another question in the Q&A pane about how some places are engaging AI to cover the gap in the healthcare workforce. Is it going to help us, or is it going to replace us, cause more trauma? Where do you think this is all? It's a huge question, but in terms using your lens of moral injury, what are your thoughts about how we could perhaps steer AI to really be beneficial rather than harmful, both for us and for patients?
So I have an answer for that, which is we just did this 10 years ago with the EMR. So we learned some really big lessons there. We have got to have members of the frontline workforce who are integral to the implementation of this, to the design and the implementation of AI in healthcare. We cannot, tech folks are really well-meaning, but they don't understand the clinic. They don't understand the stakes there. They don't understand how easy it is to get it wrong. And so we have got to have a robust workforce that's involved in helping to design and implement that.
Yeah,
We did this not long ago.
Yeah. Go ahead.
I want to make one comment on somebody who mentioned in Q&A. They asked, do you see this in other places? Right? Do you see parallels between these problems and those in higher education? 100%. So we have heard from educators, veterinarians. I'm working with the public defenders at a national level. We have heard from people in management consulting. It is in many, many places. And yes, the book would probably be relevant. I've had a lot of lawyers read it. I have had educators read it. And so, yes, I think it would be relevant for social workers.
Relevant for everybody, just to be more aware of the context of the country we live in, really.
I mean, we wrote it, I wrote it and my publisher encouraged me to write it for a lay audience. So it's not written for a clinician audience, because I think patients need to know about this, and we're all patients.
Right. And the more we can join forces to advocate for what's right, the better off we're going to be. I highly recommend the book, by the way, folks. I think it's incredibly valuable, and it's just peppered with very important personal stories of the people that Wendy interviewed. It's very, very moving and informative. Another question here, would you comment on what seems like an ever-increasing competitive compensation for healthcare C-suite people, and how this is perceived by the healthcare workforces as part of our moral injury?
So I think I have a couple of thoughts on that. Not every healthcare CEO makes 7-8-figure salaries. There are some who are extraordinarily hardworking, who are in rural areas, who get a tiny fraction of that, who don't make as much as their clinicians do. So that's the first thing I'd like to keep in mind. But yes, it's become sort of an arms race in the higher levels. And we absolutely need to be saying something about that. We need to hold boards responsible for those compensation calculations. And we need to start asking places like CMS to weigh in on that. Is it okay that a CEO is making 7 figures, 8 figures?
Especially if the system's going under. Yeah.
Yeah, so right. And that's one of the things that I talked about in the book is where's the National Healthcare Executive Data Bank?
Yes. Can you talk more about that? I thought that was a really interesting idea.
So any clinician will know that there's a National Practitioner Data Bank. What I noticed when I was writing the book is that too frequently, some of the worst actors would get a healthcare system in trouble. They would go underground and then they would pop up in another place a few years later. With clinicians, we have a record of that is in perpetuity in the National Practitioner Data Bank. As healthcare consolidates and as corporations start making, start putting constraints on care or deciding certain things about the EMR that drives our healthcare, or starts implementing AI that makes healthcare decisions or diagnostic decisions, I think we need to start acknowledging that it's not just clinicians who are responsible for the care that we get. Because of that, I think it's important that we start acknowledging that we need to track some of those decisions and to put in place some way of immortalizing some of those decisions that folks make. With a national, and it could be a National Healthcare Executive Data Bank, something like that.
Yeah, so a way to hold people accountable. There are more questions in here. I actually, because it feeds right off of this about the CEO compensation. There's another question that asks, have you seen differences in moral injury rates in for-profit versus nonprofit systems? No.
Because the truth is that, as I said, with business schools changing their curricula, lots of the folks who run healthcare systems have MBAs. When they go to business school, many of them are taught in this sort of shareholder primacy way. And many nonprofit systems are run very similarly to for-profit systems, but there's different terminology. Instead of profit, it's excess revenue. And instead of paying back shareholders, it goes into capital expenditures.
Huh. And they also, nonprofits also have to demonstrate how they're serving communities and, but.
Yeah, but there are a lot of ways that you can do that. If you do research, you can be considered community benefit.
Right.
Doesn't have to just be charitable care.
Yeah. There's another question sort of building off of this, the differences in prevalence and severity of moral injury observed here in the US versus places with universal health care. You're working with the UK collaborator, Deborah Morris. What's her take on this or yours?
So we're working with Dr. Morris in the UK. We're also working with folks in, we've heard from people in Germany, France, New Zealand, Australia, Mexico, lots of other places. And the challenge is that the drivers may be slightly different. So in the US, it's largely this financialization or profit motive. In the UK and France, it's that legislators aren't appropriately resourcing the healthcare systems. So it all boils down to, I can't care for my patients the way I would like to, but we haven't had a national conversation about what our values in healthcare are. And we haven't come to a collective agreement about what that means, what our values are, and what they're worth to us. Now, places like New Zealand have a smaller population. They have been much more intentional about having those conversations, so it's not quite as fraught. But in order to get to the heart of this, and in order to really insulate us from moral injury, or to be able to have these conversations out in the public, I mean, to have these conversations on a regular basis in healthcare, we as a country, we as a society need to have that bigger conversation. What are our structural determinants of health?
And the structural determinants are really upstream to what we're seeing in healthcare. Yeah, go ahead.
Yeah, no, I mean, it's the financial decisions that we make. It's our economic decisions. It's our policies and our regulation, our governance. How do we choose where we put our money? How do we choose what we value in healthcare? So
How do we have that kind of collective conversation nationally, especially in the current, polarized climate in this country? It seems like that has to happen, and I think it's a source of frustration and sadness that it doesn't. But as you said, we need to be hopeful. We created this, or someone created this, and we can either choose to acquiesce to the conditions that we live in, or we can push back against them. So how do we have that kind of larger conversation across a polarized society? It's a huge question. I know. I saw.
yeah, oh,
Sorry.
I've got 5 minutes to answer that.
No.
No problem. So I mean, I really think that the first place we start is to be curious about each other. Start from a place of of where we presume charity, right? Where we don't look at someone who has a different perspective and automatically see them as the enemy, where we look at them and say, gosh, I wonder why you hold that view so tight. Explain it to me. Maybe I have something to learn here. And the more we can look for commonality, the more we can look for that curiosity and try to see more how we're alike rather than how we're different. And man, we can just practice that in our organizations, right?
Yeah.
We
Yeah.
can just practice that with our administrators and with our leadership.
Uh-huh. Yeah, I mean, I think the key is start where you have some personal control. You can't boil the ocean, but you can start one conversation at a time. There's another comment in the chat from Dr. Michael Gustafson saying, over the past 3 decades, many more physicians, nurses, and other providers are administrative leaders and trying to accomplish both objectives, maximizing patient care while keeping the hospitals healthy, but often are frustrated trying to accomplish this. And it's really a fundamental challenge, the fragility of the entire financial underpinning of the healthcare system driven by state, federal, governmental policies and investment decisions, which I think is exactly what you've highlighted, today and in your book.
Yeah.
There's
I also wanted to just make a note of the comment above that, which is there any difference between teaching hospitals and community hospitals?
yeah.
And people who are interested should really read. I talk about that a little. I talk about rural hospitals a little bit in my book. There's another book called The Hospital by Brian Alexander that talks all about a rural hospital. We, on 43cc, we had Brian Alexander as a guest. And then the next episode, we had the CEO of that hospital, Phil Ennin, as a guest as well. And it was they were fascinating conversations. So I would encourage people to go and have a listen to the 43cc podcast for those. We also, by the way, talked to a Boeing whistleblower.
Interesting. Okay. That's
and to the former corporate communications lead for Cigna Healthcare.
Well, I think one of the things that's also appealing about what you're saying is, yes, administration and the clinical side are sort of siloed from each other. But we have to figure out a way to link that, to break down those silos, to increase the communication, and to really help all of us understand what it's like to be in the shoes of the other, so that we don't other and marginalize those whom we, want to blame, because that is going to be unproductive. And I see that Julie has come back, which means we have to start to wind down the webinar.
Yeah, I'm going to put my email in the chat, so anybody who wants a question answered that didn't have a chance.
Yes. There's so much here still to comment on. I really feel Kayla's, Trent's comment here too about it feels like insurance companies make healthcare decisions, not physicians. And again, it goes back to thinking about where can I make a difference? What are the immediate things that I can do? And you sort of nicely listed that. And talking about supporting the leaders, speak up but not alone, form coalitions, educate politicians, advocate with your legislators, all those things that you recommended. And this webinar is being recorded. It'll be archived on our website if you want to go back and look at it later. So I'm going to turn this back over to Julie now to close us out. And thank you so very, very much, Wendy, for this conversation.
Yeah, it's my pleasure.
Thank you, Beth, and a heartfelt thank you to you, Wendy, and to all of you who have joined us here today. We hope you enjoyed this Compassion in Action webinar. Please keep an eye on your email for news of future events. And please also check out our website for information on how to nominate a caregiver or program for one of our 2 award programs. Thank you again for being here today.
Thank you all.